Okay, so I'm going to talk quickly now about breech presentation. And again, you'll be familiar with this, I guess, from your knowledge of treating pregnancy or normal pregnancy and using moxibustion. But I just thought I would link it into cord prolapse as a red flag, because the incidence of cord prolapse is much higher when there's what we call a malpresentation. So just bear with me while I quickly tell you the different types of breech. There's a little diagram there showing you a flexed breech, which can be extended or frank. So there's the frank breech is where the baby's legs are up, straight up. And then we have a footling breech, where the foot is coming down first, and a complete breech where the baby's sort of sitting on its legs. And there we have the picture in the womb of the baby upside down, and also we've got twins here, where one twin is breech and the other is cephalic. By the way, if you don't already know this, moxibustion shouldn't be used for multiple pregnancy, even if twin 1 is breech. It's not safe. If twin 2 is breech, if twin 1 is head down but twin 2 is breech, it doesn't really matter, because when twin 1's got out of the way, twin 2 usually swings round to head first, or it can be moved round by the person delivering the baby. They literally grab hold of the baby and get it in the right position. So just to add that in. And we've used moxibustion for years in our unit. I was allowed to do it before I was even allowed to needle back in 1988. And this is women in China using moxibustion. I'm pleased to say we don't do it quite like that. We actually sit and hold the moxisticks for the women. We teach their partners what to do, and they take the treatment home and do it themselves there daily to bladder 67. It's a fairly standard part of pregnancy care, so I'll move on, but I'm very happy to come back to that later if anybody not familiar with it for any reason wants to talk a bit more about it. So the problem with a breech and a malpresentation is that the cord can prolapse downwards. The incidence is about 0.2% of all births. It's more common in preterm pregnancies because the baby doesn't fit quite so well, or doesn't act as a plug quite so well to stop the cord coming down. And it's more common when the baby is in an abnormal position. The complications are mainly to do with the presenting part of the baby not fitting well, and if the membranes rupture, the cord can slip down the side. The management is to call for help, 999 in our country, and I believe it's 911 where a lot of you are in the USA and Canada. She needs to be put into the knee chest position, and I've got a slide of that coming up. And she needs to keep breathing, and I mean yes you, because if it happens it's pretty scary. Just by way of acupuncture, you could consider, if it's appropriate, while you're waiting for the ambulance, to needle Shen Men, Heart 7 or ear Shen Men for her anxiety, but obviously only if it's appropriate. And if you've got ambulance technicians rushing in the room, then please let them get her on the stretcher and don't ask them to wait while you put a needle in. There are many different types of presentation. The incidence of cord prolapse is 4 times more common with preterm pregnancies, and the perinatal mortality rate associated with it is very high at 9%. But some of these rates may be due to the fact that the baby's premature and has a low birth weight, but obviously it's not good news for the baby because the oxygen and blood supply is being cut off. One of my colleagues, there are 3 acupuncture midwives on my team at Plymouth, and one of us works in the delivery suite full time, as well as doing acupuncture. And she told me of a case of a lady who was having her membranes ruptured to induce her labour. And the baby's head was high, so they did it slowly. They made a hole in the membrane bag and just tried to make it as small as possible so that the fluids drained out slowly. But nevertheless, the baby's cord slipped down in front of the baby's head, even though it was head down. And when the midwife examined her, she could feel the cord there pulsating. And so the woman had to quickly be rushed to theatre for a caesarean section. The baby cannot be delivered with a cord prolapse vaginally. It would not survive. And so it's not a very good slide, I apologise, but just to show you the different types of presentation, even with head down, that the baby can be in an abnormal position. There can be the face presenting. So here we have brow presentation and face presentations, all very difficult, maybe obstructed labour, maybe potentially possible to have a cord prolapse, and again we've already talked about breaches. Posterior position, by the way, of course, just going back to normal labour, we can do a lot with points such as bladder 67, either needling in as part of preparation for labour, or using it with acupressure, or ear press needles being put on bladder 67 to encourage a baby in the posterior position to rotate and therefore a much better labour. Here's a slide of prolapse cord. There's the baby in the breech position and the cord has come down. There's the cervix dilating, and this cord is going to get obstructed. And here's a baby in a head first position where the cord has prolapsed down and the cervix is dilating. So more likely with, we were talking about hydramnios and polyhydramnios earlier, loads and loads of fluid, baby's head is high, the membranes rupture, the fluid leaks down because there's so much of it, an abnormal amount, and the baby's head swiftly follows, but unfortunately the cords managed to get there first. So greater incidence with polyhydramnios of cord prolapse. And women with polyhydramnios may well be admitted to hospital to rest, just in case it does prolapse. For those of you who haven't seen it or aren't familiar with it, here's an umbilical cord. Can't get my pointer to work now, but you can see the cord there with there we go, the big blood vessels. There's the compared to the fingers there, you can just see how huge these blood vessels are. So the risks of cutting that supply off. And I talked earlier on that should a cord prolapse and you happen to be in the very unfortunate position of being there when it happens, the woman should get into the knee-chest position, and this will get the weight of the baby off the cord to buy some time, or possibly into the left lateral position, again to get the weight of the baby off the cord while emergency help arrives. So I hope those are helpful to give you some idea of what can happen with the cord prolapse.